Glaucoma is a group of eye diseases that is characterized by intraocular hypertension, or in other words, increased pressure within the eye. It's also classified as any eye having an intraocular pressure greater than 22 millimeters of mercury. So why is glaucoma bad? Well, the issue is that as the pressure increases inside the eye, we can develop damage to the optic nerve, the thing that sends image signals to our brain and allows us to see. This damage can eventually lead to permanent visual loss or blindness. So let's orient you to the eye. We have the cornea, a clear front window of the eye that transmits and focuses light into the eye. Next is the iris. This is the colored part of the eye. Now, besides creating beautiful eye colors, it also has muscles that allow it to constrict and relax to regulate the size of the pupil, or the opening in the eye. The size of the pupil regulates the amount of light that enters into the eye. We then have the lens. This is a transparent, flexible tissue that is located behind the iris in the pupil. It also helps focus light and images onto the retina. The lens can lose its elasticity over time, causing difficulty in focusing on near objects, hence why we need reading glasses when we get older. At the very back of the eye, we have the retina. This is what senses light and creates electrical impulses and sends them through the optic nerve, which allows us to see. The eye also consists of three chambers: the anterior chamber, which is the region between the cornea and iris, the posterior chamber, or the region between the iris and lens, and the vitreous chamber, which is located in the back of the eye and contains vitreous fluid. The anterior and posterior chambers are both filled with aqueous humor, which is a clear, watery fluid. It's produced by the ciliary body, a ring of tissue that sits behind the iris and helps bring nutrients to the eye tissues and maintains intraocular pressure. As aqueous humor is continually produced by the ciliary body, it flows through the posterior chamber to the anterior chamber through the pupil, across the iris, and to the trabecular meshwork, which is essentially a drain. It then goes into a collecting duct known as the canal of Schlemm, and eventually into the episcleral veins where it can be absorbed by the bloodstream. So I want you to think of this as a highway within the eye, with traffic flowing in one direction from the ciliary bodies to the trabecular meshwork. So what causes glaucoma? Well, this occurs when essentially we have something we have all probably experienced when driving to Atlanta: a traffic jam located along our aqueous humor highway. Something is causing an interruption in the flow of aqueous humor, and we start to get a buildup of the fluid, thus creating pressure, or increased ocular pressure, within the eye. This buildup of pressure affects all structures of the eye, including the optic nerve, which is what carries all visual information to the brain. If the optic nerve continues to get damaged, over time, this can lead to vision loss. There is no treatment for glaucoma once the damage is done, so in our patients, our goal of therapy is to prevent further damage to the optic nerve. Risk factors for glaucoma include older age, a family history of glaucoma, the African American race, use of systemic or topical corticosteroids, and patients with high intraocular pressure. There are three types of glaucoma: open angle, narrow or closed angled, and normal tension or low tension. Today, we'll be primarily focusing on open angle and closed angle glaucoma. The most common type of glaucoma is open angle glaucoma, with approximately 90% of all glaucoma cases. Open angle glaucoma occurs when the angle between the cornea and iris is open and normal, but the drainage system or trabecular meshwork slowly gets clogged. This is kind of like when an accident occurs on a highway. The aqueous humor is no longer able to be drained, and this results in a gradual increase of pressure within the eye. This leads to outer rim atrophy of the nerve, which can then cause peripheral vision loss. Eventually, the eye will get further damage to the optic nerve, and central vision loss can occur. There is also narrow angle glaucoma, or angle closure glaucoma, or closed angle glaucoma. And this happens when the angle between the iris and cornea is too small as a result of the lens being pushed up against the iris, almost like an entire road closure. This can lead to a rapid pressure buildup, which is called acute angle closure crisis. Patients may experience eye pain, redness, blurry vision, headaches, nausea, and visual halos. This should always be considered a medical emergency as it can very quickly lead to permanent visual loss. To diagnose glaucoma, intraocular pressure is assessed through ocular tonometry. You know, that fun machine that puffs air into your eyes at the optometrist. Other tests conducted, especially in glaucoma patients, includes visual field testing, where the optometrist is looking for optic nerve damage. On the left, you'll see a normal eye with a blind spot located where the optic nerve is, whereas on the right, we'll see a damaged eye with multiple blind spots representing visual field loss. As mentioned before, glaucoma is not curable, but the progression of damage caused by increased intraocular pressure can be managed with medications. There are 3 ways that medications are used to help lower intraocular pressure. 1. Decrease the production of aqueous humor. 2. Increase the outflow of aqueous humor. And 3. Both decrease the production of and increase the outflow of aqueous humor. Surgery is also available to help with glaucoma. There is trabeculoplasty that's used in open-angle glaucoma, where a laser is used to help open up the trabecular meshwork to allow for aqueous humor to flow. In closed-angle glaucoma, there is a procedure called an iridotomy, where a laser is used to put a hole in the iris, and this is the definitive treatment for acute angle closure crisis. To treat glaucoma, we use eye drops to provide drug therapy at the site of action. However, there's something a little unique and important with eye drop medications. You see, we have something called the nasolacrimal duct that carries tears from the lacrimal sac of the eye into the nasal cavity. The issue is that when medications are given in the eye, it can lead to systemic absorption of the medicine via the nasolacrimal duct and therefore cause systemic side effects. To help prevent systemic absorption, we can do something called nasolacrimal occlusion, or simply placing your finger on your tear duct and pressing slightly while the eye is closed to prevent absorption. It's recommended to do a nasolacrimal occlusion for about 3 minutes after administering an eye drop to help prevent systemic absorption. Now I'd like to quickly go through the different therapies available for open-angle glaucoma, which will be covered more in depth in lecture. The first class of medicines are those that decrease aqueous humor production and includes the beta-adrenergic receptor antagonists and the carbonic anhydrase inhibitors. Beta-adrenergic receptor antagonists, or beta blockers such as timolol, are eye drops that generally have a yellow cap and are usually dosed twice daily. They lower intraocular pressure by about 20 to 30%. Beta blockers are generally well tolerated with some stinging upon administration. Keep in mind that these medications are beta blockers, and therefore, if they are systemically absorbed, they can lead to a systemic beta blocker side effects. Patients who take large amounts of the eye drops or do not properly occlude the nasolacrimal duct may notice decreased heart rate or exacerbations of respiratory issues. Therefore, it's recommended to be cautious when using these medications in patients with asthma or COPD. Carbonic anhydrase inhibitors, such as dorzolamide or brinzolamide, also decrease aqueous humor formation. They generally have an orange cap, but have less decreasing intraocular pressure compared to beta blockers and other agents, of about 15 to 26%. These are normally dosed 2 to 3 times daily. Another unique thing about the carbonic anhydrase inhibitors is that this class has oral medications that can be taken with the purpose of lowering intraocular pressure. However, the systemic use of these medicines is generally reserved for acute issues such as acute angle closure crisis to lower the intraocular pressure quickly. Generally, systemic carbonic anhydrase inhibitors are not used chronically given their many intolerable side effects. The next group of medications includes those that increase the outflow of aqueous humor, or the prostaglandin analogs, such as latanoprost. Prostaglandin analogs typically have a teal cap and are used generally as a first-line agent. They're typically dosed once a day in the evening and are relatively cheap and effective at lowering intraocular pressure with about a 25 to 35% reduction. This class of medications has unique side effects, such as hypertrichosis or elongation of eyelashes, which is what led to the creation of Latisse for eyelash extensions. It can also cause periocular hyperpigmentation, or the darkening of the skin around the eyes. Both of these are reversible once the medication is stopped. Another side effect with the prostaglandin analogs is that it can change the pigmentation of the iris. This generally occurs in light-colored eye patients, and over time, the iris can change to a darker color. This is extremely important to counsel on, as it is irreversible once it does occur. The last common class of open-angle glaucoma medications are the alpha-adrenergic agonists, which both decrease production and increase outflow of aqueous humor. Alpha agonists, such as brimonidine, typically come in a purple cap and are dosed 2 to 3 times a day. They are structurally similar to clonidine and reduce the intraocular pressure by about 18 to 27%. Many of these medications also come in combination drops. This allows for improved adherence, but be wary, as many combination eye drops are available as brand name only and may not be covered by patients' insurance. Remember, open-angle glaucoma generally doesn't have symptoms, so patients may stop taking their medications because they feel okay. So anytime there is therapeutic failure, it's always important to assess adherence with your patients to make sure that they've continually taken their medication.